Congenital heart disease is structural abnormality of the heart present since birth. They are broadly classified into the acyanotic congenital heart disease, which involves left to right shunt or obstructive lesion without early life cyanosis, whereas in cyanotic congenital heart disease involves right to left shunt or mixing of blood leading to systemic desaturation or early life cyanosis. Now, acyanotic and cyanotic congenital heart diseases are further classified into the volume overload, pressure overload. So, acyanotic is further divided into volume and pressure overload. Now, volume overload is caused by the left to right shunts, AV regurgitation, and cardiomyopathies, whereas the pressure overload is due to the outflow obstruction or inflow obstruction. So, inflow obstruction is obstruction of blood flow from atrium to the ventricle, which is caused by the tricuspid stenosis, mitral stenosis, and cord triatriatum. So, in this tricuspid, flow from right atrium to right ventricle obstruction, whereas in mitral there is from left atrium to left ventricle obstruction. In this cord triatriatum, there is a fibromuscular septa noted in the left or right atrium lead to the inflow obstruction, whereas in the outflow obstruction at the level of valve, below the valve level and above the valve level. So at the valve level there is valvular pulmonic stenosis, valvular aortic stenosis, coarctation of aorta, whereas the below the valve is double chambered right ventricle sub aortic membrane, whereas in the above valve, that is the branch pulmonary stenosis, supravalvular aortic stenosis. So these are the acyanotic congenital heart diseases, whereas in the cyanotic there is decreased pulmonary blood flow and increased pulmonary blood flow. So in decreased there is a tetralogy of Fallot and tricuspid atresia, whereas in the increased pulmonary blood flow, TGA, total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart. So these are the classification of acyanotic and cyanotic congenital heart disease. Now the acyanotic congenital heart disease, that is the left to right shunt. So before going to the acyanotic or congenital heart disease, let's know briefly about the basic mechanism of normal blood flow. So what happens that the blood from the body goes into the IVC and superior vena cava, through which it drain into the right atrium. From right atrium it goes into the right ventricle, and from there goes into the pulmonary artery and into the lung, where it purifies, and again through the pulmonary vein from the lungs on either side. Through the pulmonary vein it drain into the left atrium and then into the left ventricle and then into the systemic circulation, that is the aorta. So this is the normal phenomena of the blood flow in heart and lung. So now let's go to the congenital heart disease. Now the basic mechanism of acyanotic congenital heart disease, where oxygenated blood from left heart goes into the right ventricle or right heart. As we can see here, there is a defect due to the pressure difference of left ventricle and right ventricle, causing pulmonary over-circulation without evidence of initial cyanosis. So this will lead to the pulmonary over-circulation, and due to the increased flow and pressure in lung vasculature, it will lead to the pulmonary vasculature remodeling, and this will lead to the pulmonary hypertension. And if pulmonary hypertension persists for long period, then it will lead to the cyanotic condition called Eisenmenger syndrome. Now the examples of left to right shunt are the ventricular septal defect, atrial septal defect, and the patent ductus arteriosus. So these are the conditions for the left to right shunting. Now, other than the shunting, there is another cause of the acyanotic congenital heart disease is the obstructive acyanotic lesions. So these are the causes: the ventricular outflow, or inflow obstruction. So pathophysiology of this is the obstruction of forward blood flow. So this is the coarctation of aorta, in which the blood flow from the left ventricle to the systemic circulation is obscured or obstructed. As we can see, there is a coarctation. So this will lead to the pressure overload proximal to the obstruction and then lead to the ventricular hypertrophy and reduce distal perfusion. Now another is the aortic stenosis. In aortic stenosis, we can see that there is a stenosis at the valvular level of the aorta or left ventricular outflow obstruction. As we can see, the valve shape while opening is a triangular shape, and while closing it is closely approximated, whereas in the valvular stenosis the shape is changed and there is no complete closure of the valve is seen. Now pulmonary stenosis. So this is also stenosis at the pulmonary artery origin or right ventricular outflow obstruction. So as we can see here, closed pulmonary valve is completely approximated, whereas in stenosis we can see the shape is changed and there is no complete closure, and the while opening there is a narrow area of lumen, and we can also see that there is thickening of leaflet, and this can cause the pulmonary stenosis.